Welcome and hello to all viewers. So start with, I would like to pose this question as to which of the following statements is false. Now, out of the five statements that are mentioned here, you have to pick one that is false. Which of the following statements is false? SGLT2 inhibitors, one, are contraindicated in heart failure. Number two, SGLT2 inhibitors are now class 1 recommendation in heart failure with a reduced ejection fraction as per ESC 2021 guideline. Or SGLT2 inhibitors are now indicated to be used in heart failure with preserved ejection fraction. Number 4, can be used in patients with eGFR as low as 20 ml per minute per meter square. Or the last option is have shown to reduce heart failure admissions. With that, in the next 20 minutes or so, I am going to talk about, is SGLT2 inhibitor now considered a heart failure medication? And then I'm going to answer a few questions and provide evidence. And then I would also briefly discuss the current ESC guidelines on use of SGLT2 inhibitors in heart failure and leave you with some practical tips of how SGLT2 inhibitors are to be used in heart failure patients. We all know that diabetes is prevalent and it is an important comorbidity, and poor glycemic control does increase the risk of cardiovascular complications. It does increase the risk of myocardial infarction, stroke, and heart failure significantly. And on top of that, it also leads to increase in the composite cardiovascular events, including cardiovascular death. Antidiabetic medications primarily are being used to control diabetes, and no doubt the efficacy as to how it improves glycemia, as to how it improves the HbA1c are the primary objective of using these medications. It is also important that these antidiabetic medications are tolerant, but beyond that, it is also extremely vital that these antidiabetic medications are safe. In 2008, FDA laid down a guideline that any new antidiabetic medications that are introduced in the market should prove their cardiovascular safety. And this was due to few antidiabetic medications that led to adverse cardiovascular effect, including cardiovascular death. Since then, 2010, rosiglitazone, and 2016, saxagliptin, which were introduced in the market and then withdrawn because they showed that there was increased risk of heart failure with these medications and did increase the cardiovascular adverse effects. So as you can see the timeline here, the diabetes medicines were primarily used for glycemic control. And then more recently, these anti-diabetic medications have gained immense popularity in terms of weight loss. So patients and some general population are also using anti-diabetic medications to help obesity and related comorbidities. But beyond the cardiovascular safety and the anti-diabetic medications that have shown that they have got not only a safety profile, but they improve the cardiovascular outcome in terms of reducing future myocardial infarction, reducing cerebral stroke, and also cardiovascular death. But more recently, they have also shown that they do have a positive benefit or a role in patients with chronic as well as acute heart failure. So in a nutshell, I'm just trying to show here as to how diabetes along with hyperlipidemia, they lead to adverse cardiac dysfunction. And primarily, as we know, diabetes leads to insulin resistance, there's inflammation, there's lipotoxicity, as well as oxidative stress. And they all lead to micro and macrovascular changes. And these pathophysiological changes also lead to diastolic as well as systolic cardiac dysfunctions. So SGLT2 inhibitor, how does it help in heart failure? Well, the honest answer is we do not exactly know as to how SGLT2 inhibitor helps the patients in heart failure. But there are certain postulations as to how SGLT2 inhibitor may be beneficial in these patients. One, we all know that SGLT2 inhibitor works at the kidney level, primarily leading to glycosuria, and it has got some diuresis effect. So essentially, it leads to hypovolemia, it leads to volume loss when there is fluid overload in heart failure patients. And it also leads to some degree, although it is a modest degree of lowering of systolic and diastolic blood pressure. SGLT2 inhibitor has also been postulated to improve the left ventricular function by decreasing the left ventricular mass. It also reduces the vascular stiffness, improves endothelial function. We also know that SGLT2 inhibitor leads to increase in the ketone production, and ketone, as you all know, is the most important fuel for the cardiac function and contractility. So in a nutshell, this is how we feel or think that SGLT2 inhibitors might be helping cardiac function and might be helping patients with heart failure. There have been a number of trials, and these are some of the initial trials that were done with SGLT2 inhibitors proving the cardiovascular outcomes. So these are the cardiovascular outcome trials: EMPA-REG outcome trial using empagliflozin, CANVAS trial using canagliflozin, DECLARE-TIMI 58 using dapagliflozin, VERTIS using gliflozin, and again CREDENCE. CREDENCE basically is a cardiorenal outcome trial using canagliflozin. And they were all looking at the primary outcome, which was a 3-point MACE, major adverse cardiovascular event, cardiovascular death, myocardial infarction, stroke, and also heart failure hospitalization. And these trials, although they were just looking at the cardiovascular death, myocardial infarction, and stroke, what was observed that the cardiovascular outcome was mainly driven by reduction in heart failure hospitalization. And if you look at these trials, EMPA-REG, CANVAS, DECLARE-TIMI, and VERTIS CV, there was a significant risk reduction in terms of reducing the heart failure hospitalization, except the EMPA-REG that also showed a reduction in cardiovascular death significantly. So that caught the attention of the scientists, the clinicians, healthcare professionals, and only then it was recognized or was thought that SGLT2 inhibitor could be a heart failure medication. But of course, this had to be proven further. So this was just by chance. It was found that it was helping patients in terms of reducing cardiovascular outcome, mainly by reduction in heart failure hospitalization. So to prove this point, if SGLT2 inhibitor is a heart failure medication, further trials were conducted. So in the next few slides, I'm going to discuss and answer the following questions. One, what is the evidence to support that SGLT2 inhibitor is a heart failure medication? Two, can SGLT2 inhibitor be used in patients with heart failure who do not have diabetes? Can SGLT2 inhibitor be used in patients with heart failure with preserved ejection fraction? How soon we get to see the effect of SGLT2 inhibitor once they are started? Can SGLT2 inhibitor be started in patients with acute heart failure? And that's an important question to answer. How soon and in what order can we start SGLT2 inhibitor in heart failure patients, particularly heart failure with reduced ejection fraction? And finally, the last question I'm going to answer is, can a SGLT2 inhibitor be used for prevention of heart failure? So number of questions, and let's see what the answers are and how they are supported by evidence-based medicine with the trials that have been conducted to prove this point. So to answer the first question, what is the evidence to support that SGLT2 inhibitor is a heart failure medication, and primarily to look at the effect and benefits in patients of heart failure, chronic heart failure with a reduced ejection fraction. And to prove the point, the first trial that was done was using empagliflozin, and the trial is called Emperor Reduced Trial, Emperor Reduced Trial, where empagliflozin was used against placebo, and the endpoint, the primary endpoint was to look at the composite of cardiovascular death or heart failure hospitalization. And the trial did show that there was a 25% relative risk reduction in terms of reaching its primary endpoint, reducing composite of cardiovascular death or heart failure hospitalization in favor of empagliflozin compared to placebo. The first secondary endpoint was mainly to look at the total, which included first and the recurrent heart failure hospitalization. Once again, this was significantly reduced, and with a relative risk reduction of 30% in favor of empagliflozin compared to placebo. So it proves the point that definitely empagliflozin is beneficial compared to placebo in patients of heart failure with a reduced ejection fraction when it was compared to placebo. A similar trial was done using another SGLT2 inhibitor, which is dapagliflozin, in the DAPA-HF trial. And once again, the primary outcome was to look at the worsening heart failure event and cardiovascular death. Dapagliflozin here was compared with placebo, and at the end of the trial, it was shown that definitely dapagliflozin did better compared to placebo in reaching its primary outcome, both in terms of worsening heart failure and cardiovascular death. And worsening heart failure was the main driving force, where the p-value, as you can see, was highly statistically significant in favor of dapagliflozin. So both these trials prove that definitely empagliflozin as well as dapagliflozin, which are the two important SGLT2 inhibitors that have been studied, definitely have got a better role to play in patients of chronic heart failure with reduced ejection fraction. Now, the second question also is raised, can SGLT2 inhibitor be used in patients with heart failure who do not have diabetes? So, SGLT2 inhibitor was being used in patients of heart failure who had diabetes, but they also included patients who did not have diabetes. And as you can see here on the slide, the patients who did not have diabetes also reached their primary endpoint, and it was shown that they benefited as well. So regardless of diabetes status, SGLT2 inhibitors reduce the relative risk for hospitalization due to heart failure by 37% at 6 months, 32% at 1 year, and 26% at 2 years' time. With that, 2021 ESC heart failure guidelines laid out few guidelines and recommended SGLT2 inhibitor to be used in patients of heart failure with reduced ejection fraction. So, and dapagliflozin and empagliflozin by name, they were recommended and got class 1 recommendation for its use in heart failure, chronic heart failure with reduced ejection fraction, and the level of evidence, as I have discussed in the trials, was A. Now, how about the ESC 2021 recommendation for patients of chronic heart failure with preserved ejection fraction? Now, unfortunately, looking at the slide, we had nothing in our hand to help these kind of patients. And as we all know that heart failure with preserved ejection fraction is a large population of patients, almost half of the heart failure patients, they have heart failure with preserved ejection fraction. And all that we could do and that was recommended was to screen these patients for underlying etiologies and to screen and help and treat the cardiovascular and non-cardiovascular comorbidities. And beyond use of diuretics just to help them decongest them, help to alleviate the symptoms and signs, we could do nothing for them to improve the long-term outcome, including hospitalization and cardiovascular mortality. So there was no treatment indicated to reduce the risk of heart failure hospitalization or cardiovascular death in this group of patients. So the question now is that can SGLT2 inhibitor be used in patients with heart failure with preserved ejection fraction? And to answer this question, you can see on the slide this Emperor Preserve trial. Now this indeed is a groundbreaking trial, and definitely it is a trial that has brought about a historical change as to how the patients of heart failure with preserved ejection fraction can benefit with the medication SGLT2 inhibitor. And in this trial, as you can see here, empagliflozin was compared against placebo in patients of heart failure with preserved ejection fraction, where ejection fraction was more than left ventricular ejection fraction was more than 40%, and the primary endpoint was once again composite of cardiovascular death or heart failure hospitalization. And it was seen that there was a relative risk reduction in reaching its primary endpoint by 21% in favor of empagliflozin compared to placebo. A similar trial called DELIVER trial was done, and here again the dapagliflozin was being studied in patients of heart failure with preserved ejection fraction more than 40% plus structural heart disease. And it was once again shown that the dapagliflozin compared with placebo did better in terms of reaching its primary outcome, which was cardiovascular death or worsening heart failure, and relative risk reduction of 18%. So 2023, ESC again had to update its heart failure guideline. And here, ESC did recommend the SGLT2 inhibitor should be used in patients of heart failure with mildly reduced ejection fraction, but also SGLT2 inhibitor dapagliflozin and empagliflozin were recommended as class 1 recommendation to be used in patients of heart failure with preserved ejection fraction in order to reduce the risk of heart failure hospitalization and also prevent cardiovascular death. How soon we get to see the effect of SGLT2 inhibitor once started? Now, based on the Emperor Reduced trial, the benefit on cardiovascular death or heart failure hospitalization or urgent heart failure care was seen only after 12 days. So the curve, as you can see, separated very early, and the benefit can be seen in favor of empagliflozin here as early as 12 days of starting the treatment. Similarly, DAPA-HF trial and DELIVER trial did show that the effect was seen as early as 28 days in DAPA-HF trial, and the benefit was seen as early as day 13 in DELIVER trial. Now, moving on to the acute heart failure. Now, once again, you have got to choose which of these statements is correct. One, acute heart failure always occurs when left ventricular ejection fraction is less than 40%. SGLT2 inhibitor is contraindicated in acute heart failure. SGLT2 inhibitor empagliflozin improves cardiovascular outcome in acute heart failure when stabilized, or the dose of diuretics need to be increased when patients are initiated on SGLT2 inhibitor. Now let me go through these and give you the correct answer. So acute heart failure always occurs when left ventricular ejection fraction is less than 40% is not correct, because acute heart failure can also develop in patients who have got left ventricular ejection fraction of more than 40%. SGLT2 inhibitor is contraindicated. No, it is not. So I'll talk to you about the trials that has shown the beneficial effects and safety of SGLT2 inhibitor in acute heart failure patients. The third one, SGLT2 inhibitor empagliflozin improves cardiovascular outcome in acute heart failure once stabilized. So this is correct, and that has been proven through trials. The dose of diuretics actually will need to be reduced because SGLT2 inhibitors themselves have got a diuresis effect. And once you start the patients on SGLT2 inhibitor, then you must remember that the dose of diuretics have got to be reduced because their requirement becomes less. So reduce the dietary dose to avoid dehydration, hypotension, and so on if the patients are on high dose of diuretics. So the answer to the question, can SGLT2 inhibitor be started in patients with acute heart failure? It comes primarily from these two trials, IMPULSE trial using empagliflozin and DICTATE AHF trial using dapagliflozin. Both the trials have been conducted in acute decompensated heart failure, and once they have been stabilized, meaning that the symptoms and signs have improved, the vitals have improved, and then they are put on SGLT2 inhibitor, either empagliflozin or dapagliflozin compared against placebo. As you can see here, the number of patients are not very high, and it is well understood that these patients are not high in number. They are relatively smaller study population, but we know the reason why. And then they are followed up for a small period of time. And here the the main outcome is to look at the improvement in signs, symptoms, improvement in the quality of life. So basically, you can see there we are looking at the clinical benefits, and these are not long trials to primarily looking at the cardiovascular death, but definitely it has again shown and proven the fact that one, these agents, they do improve the clinical outcome, the primary outcome, which is the clinical benefit, using the SGLT2 inhibitors in these acute heart failure patients. But more importantly, it has also shown that they are safe and cause no adverse effect. The third trial is the soloist WHF trial. WHF is worsening heart failure. And soloist WHF trial used sotagliflozin, one of the other SGLT2 inhibitors. And here it showed that the chronic patients, if they have got worsening of signs and symptoms, which is a definition for worsening heart failure, then definitely they lead to better primary outcome, including reduction in cardiovascular death and hospitalization due to heart failure, and also urgent visits to heart failure. So worsening heart failure patients, they are a special group of patients. They need to be recognized. They must be diagnosed. And if they are started on sotagliflozin, then definitely they have got better primary outcome. Now, how soon and in what order can we start the SGLT2 inhibitor in heart failure patients? So traditionally, these were done in a conventional manner where these patients would be started on ACE inhibitor and an ARB, and then a beta blocker would be added, then an MRA would be added, and then ACE inhibitor or ARB would be changed to neprilysin inhibitor with sacubitril and ARB combination, and then only SGLT2 inhibitor was added at the end. But now we know that SGLT2 inhibitor has got the role to play, and it helps in diuresis. So the first agent amongst these should be SGLT2 inhibitor. And the advantage of using it is that you may reduce the dose of diuretic because it has got a decongestive effect. So SGLT2 inhibitor should be the first medication to be used. Then you may add MRA, and MRA again is a diuretic, so it will help to decongest and also reduce the dose of other diuretics that are being used. And then also the ACE-ARB or ARB plus sacubitril, which is neprilysin inhibitor, can be used, and then you can use a beta blocker. So essentially, all the four medications, they have got to be started within 4 weeks, and that is the current guidelines. All medication they have to be starting with SGLT2, MRA, and then you can add the other two, so which are the four pillars of heart failure medication. and should be added within 4 weeks' time. More recently, ESC 2023 focused heart failure guideline has also recommended that we should also use SGLT2 inhibitor in patients of type 2 diabetes mellitus and chronic kidney disease in order to prevent future heart failure. And again, it is class 1 recommendation with level of evidence A. So finally, I will leave you with some practical tips of using SGLT2 inhibitor in A heart failure. So start early, even in stable at-risk heart failure patients, post-MI patients. Now I've showed you the last slide. What is the evidence? So if the patient develops MI, and if particularly they have got a poor LV function, no signs, symptoms of heart failure, they should be initiated on SGLT2 inhibitor to prevent future risk of heart failure in these patients. And evidence has shown, and it is very clear, that SGLT2 inhibitor can be used across all spectrum: heart failure with reduced ejection fraction, heart failure preserved ejection fraction, and also acute heart failure patients, irrespective of the diabetes status. Whether they have diabetes, whether they do not have diabetes, they all benefit from SGLT2 inhibitor. And as I already said, can be used in acute heart failure patients once they have been stabilized. And it does help to decongest. So if the patients are on diuretic dose, so diuretic dose has to be reduced in these patients in order to avoid dehydration. We know that SGLT2 inhibitors also improves the EGFR kidney function, and there have been several trials that have been done using SGLT2 inhibitor in chronic kidney disease, such as EMPA renal trial and DAPA-CKD, and they have also shown that the SGLT2 inhibitors are actually beneficial in patients of chronic kidney disease in terms of improving uh, the primary outcome. And we have noted in the trial that once the SGLT2 inhibitors are started, there's initial dip in the EGFR. So this is due to some hemodynamic changes that take place in the afferent and efferent arterioles. And so some initial dip in EGFR is expected, but do not stop the SGLT2 inhibitor with the fear that it's going to lead to adverse kidney effect. But on the contrary, we all know by now that SGLT2 inhibitor have got beneficial effect on the kidneys. So do not stop and continue to use SGLT2 inhibitor, and certainly they are going to have a better cardiovascular, better renal outcome. So with that, I thank you very much